Just 30 years ago, it was a common belief that a surgeon would decide which operation to perform right during the surgery after performing a laparotomy, that is, a large incision in the abdomen. And only then would he feel the tumor and say, here, we can do a sphincter-preserving operation, but here we'll have to remove everything. The patient himself, up until the end of the operation, still didn't know exactly what kind of procedure he would undergo or what he could expect. Why was it like this? Because there were no modern diagnostic methods. There was neither CT nor MRI, and the surgeon had to make this decision during the operation. Now, in the era of modern diagnostic methods, I, as a surgeon, have the ability to plan my operation in advance. For this, I actually need a high-quality MRI to plan surgery for rectal cancer, where I can clearly see the blood vessels, the spread of the tumor, and the wall of the rectum. Can I perform a standard operation, or is it necessary to carry out a more extensive procedure? What extent of lymph node dissection is necessary for this patient? Is the standard approach sufficient, or is it necessary to perform an extended lymph node dissection if there are enlarged or affected lymph nodes in the spaces around the rectum beyond the area of a standard operation? It is impossible to determine this without an MRI. And in cases of colon cancer within the abdominal cavity, CT scans also allow us to study the vascular anatomy, which is highly individual for each person. And even during surgery, it is not always possible to determine this individual vascular structure in advance and perform a high-quality lymph node dissection. It is much safer and much more reliable to study the vascular anatomy using CT before surgery, to plan the operation in such a way that it takes less time and is much more radical and effective, because the surgeon knows exactly what scope of surgery he will perform. And most importantly, the surgeon can clearly provide information to the patient about the scope of the upcoming surgery. And nowadays, answers like, we'll see during the operation, or maybe there will be surgery with a stoma, or maybe without a stoma, we'll decide as we go, should not be given. For this reason, the clinical guidelines for the treatment of rectal cancer and colon cancer specify diagnostic methods to determine the extent of the disease and to make the right decision about which surgical intervention is possible and feasible for each patient. Both the doctor and the patient should know with almost absolute certainty what kind of surgery is ahead